Without further ado, I would like to introduce today's presentation. So in general, the purpose of bite-sized lectures is really to address a clinical topic from different angles highlighted by different clinicians at the bedside. So that can be a physician, a pharmacist, a nurse, PTOT, any of our clinicians that serve on our teams. So today our presenters include Dr. Matthew Delaney, Dr. Emily Green, and Mr. Trent Trammell, who are all ED clinicians on the ED team at UAB in Birmingham. And they will be talking to us on the use of microdose or push-dose vasopressors from the perspective of physician, pharmacist, and nurse. We're really excited for this topic. I know it's a hot topic, and personally, I know our institution, this topic has come up, so I'm very interested to learn more. What we'll do is we'll allow our presenters to give us their thoughts and their presentation, and at the end, we'll have time for Q&A. If you guys are interested, please jot down your questions as you're going through. You also have a bar where you can actually type in your questions inside the text box, and we'll take all the questions at the end. And with that, I will hand it over to our presenters. Welcome.
Thank you. I'm Matthew. This is Emily. This is Trent. And I guess I'll kick it off for us. I'll just turn the camera so you guys don't have to look over my shoulder as I talk. So I think bite size is the best description of this topic, this push dose, microdose pressors, because we set out to kind of do a deep dive into what is this practice? What do we know about it? How can we use this effectively? And the answer is we know very, very little. So what we're going to do is we're going to walk through what do we know? What are we talking about? It's a little unsatisfying, as you'll see. There's a lot of practice patterns, not a lot of evidence when it comes to push dose or microdose pressors. But then we want to shift because we want to not just settle on, hey, we're doing this, but we don't have a lot of evidence. We want to look at a practice that is a common practice for most of us and try to see are there ways we could be more effective and safer with this. And that's where we shift into the whole idea that rather than push dose pressors, do we approach this with the mindset of this is a microdose pressor? And Emily's going to kind of bring us home on that. So we all work at UAB. We have no disclosures other than we use bolus dose or push dose or microdose pressors. We struggle with this as much as anybody else, I would imagine. We're a large, busy department. We are a setup for medication errors because there's a lot of enthusiasm about the idea of doing push dose pressors, but we don't have a lot of standardized systems. So we with all of you, are still trying to figure out how do we use this to help our patients at the bedside. They say you're supposed to start every lecture with a case, and I always hate that because it's always too much details, and I don't really want to listen and see what the patient's vital signs are. But I think in this situation, we'll make the case really simple. This patient comes in, they are not breathing well, they are very sick, they're hypotensive and they're bradycardic, and we need to intubate the patient. But nothing about their physiology is reassuring. And we're all looking around the room and we all think the chance that this patient's going to have an adverse event and probably very directly a cardiac arrest following the intubation, we think the chance is high. So the pressure worries me, the bradycardia worries me, we got to do something. And I ask, it's after hours, we don't have a pharmacist there. And so I ask, can we get an infusion of norepinephrine? And somebody scurries off. I have this patient who's actually dying in front of us, and we wait and we wait. And we still don't have the ability to get this norepinephrine infusion going. So we start to think, what are things we could do? I've listened to some podcasts recently. I've heard about push dose pressors. And so I'm asking someone to mix it up for me, or I'm trying to figure out how to mix up these push dose pressors. And that's the real situation, which is no matter what's made the patient so sick, we need to do something to fix their hemodynamics or to improve their hemodynamics. We need to do it really quickly. And often, as we'll see in the literature, this surrounds an intubation event. It's kind of the setting where this seems to pop up the most. And so again, I think if you've worked more than a shift in the ED or the ICU or the PACU or the step-down units, you can relate to the situation where something bad is happening, something worse is going to happen if we don't do something really quickly. And Emily's going to walk us through when we talk about push dose pressors. Again, that's a broad title, but Emily, specifically, what are we going to focus on in the next couple minutes?
So let's look at phenylephrine and epinephrine, their effects, and then we're going to sort of compare and contrast these agents and who we might use them for. So they both are considered vasopressors. Epinephrine is also considered an inotrope. Now with phenylephrine, we have pure alpha agonistic properties. But with epinephrine, we get beta 1, 2, and we are also going to hit the alpha receptors. These both have very quick onset within about a minute, and their duration is similar, roughly 10 minutes, maybe a little shorter for epinephrine. And I did want to remark, on here you see common concentration of 100 mics per ml. And I also, just reading in the literature, that's a very common concentration available. There's also a less concentrated form of 40 mics per ml. We use that at our institution, and I've heard of that used in other institutions too. Epinephrine usually is recommended to use at about 10 micrograms per ml. So the dosing with phenylephrine is going to be 50 to 200 mics at a time. And with epinephrine, 5 to 20 mics at a time. So with phenylephrine, usually the patient you're going to use this in would be hypotensive and tachycardic. And with epinephrine, you're going to see more that low cardiac output associated with shock, usually maybe bradycardic patient. And then as far as adverse events, with both, you can see rebound hypertension. With phenylephrine, you may see bradycardia, and with epinephrine, tachycardia.
And so we keep using the term push dose pressors or bolus dose pressors or microdose pressors. And this term just kind of popped up in the emergency department a couple of years ago, was when I first heard about it. And so we wanted to walk back and say, where did this come from? If it's popular, if we're all doing it, if we're all struggling to do this effectively, why are we even talking about this? And when you talk to anesthesiologists or anybody that works in anesthesia, this is kind of second nature to them. They have drug boxes, they grab these syringes, and they'll all tell you, yeah, we'll push some pressors here and there. When you ask them for, do you have evidence to back up this practice? They get very quiet and kind of disappear into the background. So really, there's incredibly limited evidence from the anesthesia and the critical care literature in terms of the efficacy of this approach and the safety of this approach. And when I've asked anesthesiologists who are friends, they get really testy and say, well, of course it works. It makes physiologic sense. We see it work. And when you ask them, like, well, great, is there a study that tells me how do I pick the right patient with septic shock to use this? When should I use this versus when should I use an infusion? They just kind of mumble and go back to the anesthesia break room. And so what we're left with is a bunch of anesthesiologists and CRNAs saying, we do this all the time. And when you go to PubMed or you do a deep dive, basically all you can find is there are some small studies almost exclusively looking at hypotension following spinal anesthesia. So really it's looking at healthy women of childbearing age who get epidurals, who drop their pressures temporarily, which is not the case that I'm usually stuck with in the emergency department. So the origin of this is really strange. I would have thought that this would have stayed as like a weird little trick that anesthesia does, because there really is not enough evidence. I would say it this way, if this were a new drug coming to market, it probably wouldn't get approved just on the basis of it hasn't really been studied. It's being done, but people aren't taking the time to write it up. So we're left with really a bizarre literature based in the anesthesia world. What happens, what's nice about emergency medicine is we get kind of the most fun parts of all the other specialties, also some of the worst parts of the other specialties. But what we've seen with push dose pressors, if we really go back and try to track, why is this a thing we're talking about now? It's this idea of taking upstairs care and bringing it downstairs to the emergency department. And so people started to hear about this from their anesthesiology friends. And a lot of the big podcasts in emergency medicine, so ERcast and EMRAP or MRAP, have about 50,000 subscribers within the world of emergency medicine. And these shows started doing segments on bolus dose pressors, push dose pressors, about 5 to 7 years ago. And so you're suddenly taking this idea that was a cool party trick for anesthesia, you're blasting it out to a ton of emergency medicine clinicians. And so there was this really rapid uptake. We started to see a lot of popular blogs, podcasts started to pick this up and do segments on it. And then at our national conferences, we have kind of thought leaders within emergency medicine saying, you know, I'll tell you how to do this. I'll tell you that this is a good practice. But again, this was not because we saw the robust literature on the anesthesia side. This was, that's a cool idea. I have a microphone and a website and it's in a podcast. And so we've gotten this incredible uptake of a technique and of an approach with medication that really, really has a very weak evidentiary base. Doesn't mean we can't do it, and we'll kind of talk about that. But again, this has gotten way, way more popular than I would have thought that it would have. And so we're kind of stuck with really trying to hone in on how do we practice evidence-based medicine. So we have clinical expertise. You will not find an anesthesiologist who is not comfortable doing this, who doesn't do this regularly. The patient values, that's, I think, a given that patients don't want to be hypotensive and in shock and have a cardiac arrest. So we don't have to worry about that one in this situation. But then the best evidence, and that's where I think I have struggled, and Emily, you and I have talked about this for years. We struggled with what does an evidence-based approach to push dose pressors actually look like? Because we have lots of clinical, quote unquote, expertise. What is the best evidence? And so I want to walk through the best evidence we have. And again, I would say that if this were a new medication, a novel medication, it would not be approved by the FDA on the basis of what we have. So this is kind of the fun part of medicine, which is how do we have these three circles overlap so we can provide really expert evidence-based care to our patients. So a brief, and it's brief, history of what do we know from the emergency medicine kind of acute care literature. So the first big publication by Panchal et al., and it's not big, but in the world of bolus dose pressors, it's about as good as we get. It's a retrospective look. It's a chart review of patients who had peri-intubation hypotension. And this was just, they said, if it's within 30 minutes before or after the intubation, we're going to say it's associated with the intubation. Again, it's a little messy to say before we tube them, that's going to be the period we're looking at. But they found 22 patients and said plus minus 30 minutes. Everybody in this cohort got push dose phenylephrine. They didn't really give us a lot of information about the dosing. It wasn't standardized because this is just a retrospective look back. And you'll see some trends in this. You'll see some things in this study that become trends. So 65% of these patients got multiple doses of the push dose phenylephrine. 70% needed subsequent vasopressor infusions. So you're doing this, you're likely to do it a couple of times, and it's a bridge. It's not definitive therapy. And it's a simple study. They said, look, we did this a couple of times on a couple of people and blood pressures got better. Systolics 73 to 93 on average, diastolics 42 to 52, and they just say there are no appreciable changes in heart rate. Okay, we don't have patient-oriented outcomes. I would not be able to get this study published if I were to write it up. So good on the authors. It's a good first look, but this doesn't really get us closer to a large evidentiary base. It's not doesn't get a whole lot better from there. So Gottlieb et al., that's one of the guys who's really beat this drum, has been a thought leader in this world, is very well respected, I think by all accounts a very good doctor, somehow published a case series of 3 patients. The patients were thought to have hypotension that was refractory to IV fluids, and everybody got epinephrine. And they got 10 micrograms every 1 to 2 minutes for 8 to 12 doses, which seems like a lot of doses to give. Everybody's pressure got better, but everybody needed a subsequent norepi infusion. So I would say that this is essentially a show and tell project with 3 patients. And again, we see when you do this, you got to give multiple doses, and you are likely to need a subsequent infusion of a vasopressor. The evidence gets a little better. So this was by Schwartz et al. In the American Journal of Emergency Medicine 2016. It's a chart review of patients who got push dose phenylephrine. None of these studies have robust methodology from a chart review standpoint. It's basically people just saying, I'll pull some charts and see what I can find. These patients, per the authors, were, quote, mostly septic shock with peri-intubation hypotension. That's at least what we're struggling with often in the ED. And I like the authors here, they throw a little shade at folks. So they said only 67% of the patients got fluids prior to pressors. So again, it's retrospective, but they're saying you did give the push dose phenylephrine, but then they weigh in and say, well, only 34% of the patients got adequate fluid resuscitation, which is interesting. And I think is one of the concerns about these new novel ways to give medications is, are we forgetting the things that we know work? If we're not resuscitating patients, do we really need to be throwing pressors at the patients or just stick with more fluids? The dosing ranges were from 100 to 200 micrograms. Again, 53% got multiple doses, 47% needed subsequent vasopressor infusions. Same story from study to study. The adverse events rates become a little problematic when you really start to focus on them. So 1 in 5 patients had an adverse event. Bradycardia is most common. Hypertension was second, and then ventricular tachycardia was in almost 3% of patients. So, admittedly, these are sick patients. These are patients who would, without the bolus dose phenylephrine, I would suspect would have similar rates of adverse events. Because this is a retrospective study, there's no control group. But I think it's important that we keep in mind that 1 in 5 patients who get these medications in some studies will have an adverse event. Doesn't mean they're dying from it, but this is not necessarily a benign intervention. Rotondo et al. Had a study in 2019 in the American Journal of Emergency Medicine. This was a retrospective look at 155 hypotensive patients broadly categorized as outside the operating room. Now, the problem was that the majority of these patients, well, the problem for us in the emergency department was the majority of these patients were peri-intubation in the ICU. So I would venture to say they're more differentiated than most of the patients we would see in the ED. They're likely better resuscitated or more adequately resuscitated just because they've had the tincture of time applied already. And the average doses of phenylephrine were 147 micrograms. They used ephedrine in this study, or they looked at patients that got ephedrine, and it was 14.2 micrograms. And interestingly, they kind of flipped the script a little bit here. The trend reverses, so only 75% got one dose. Maybe that's just because these patients were farther along in their hospitalization in the ICU, but it's interesting. So the majority did not need subsequent doses, and only 28% needed ongoing vasopressor infusions. So this one goes against the trend that we'd seen in the others. And they said that, interestingly, it didn't seem to improve that much. Systolics went up 32.5%, diastolics went up 27%. Adverse events rates here were half what we saw in the previous study. So 1 in 10 patients had an adverse event, and they categorized an adverse event as, did your systolic go up by 100? Did your heart rate go up by 30%? Or did you have a dysrhythmia? I don't really care if your systolic transiently goes up. I don't really care if your heart rate transiently goes up. I would care if you had a dysrhythmia. We don't have, unfortunately, a lot of granular details about what happened to these patients. This is also retrospective, so we don't know if something bad happened. Was it going to happen anyway? Or did this medication, did this approach with these pressors get us that adverse event? And this is, I think, the first look we see at medication dosing errors. This will come up again and again, and this is kind of the spark that got us thinking about this whole topic. 8% of patients had a dosing error, and that was phenylephrine dose of over 200 micrograms or ephedrine over 25 micrograms. I think the most interesting study came out in the same year in 2019 by Cole et al., and it was in the Journal of Medical Toxicology. And so this was a structured video and chart review, and the methods here are pretty good. And so basically all of the resuscitations were filmed from 2010 to 2017. So they would pull the file of the resuscitation, they would pull the patient's chart, and they looked at anybody who was over 16 years of age who got a push dose pressor during resuscitation. And they said that any dose of phenylephrine given during the resuscitation would count as a push dose pressor. And then if it was epinephrine less than or equal to 100 micrograms, that's who was included in this chart review. So they're looking at the video of what happened in real time. They're also looking at the chart. They had 249 patients. So one of the bigger studies we've got, the average doses of phenylephrine were 100 micrograms. With epinephrine was 20 micrograms. Adverse hemodynamic events, this is the highest rate of events we see. It's 39%. And the phenylephrine group had 27% rate of adverse hemodynamic events. Epinephrine was almost double that at 50%. They don't really get into why they thought that was, but this is one of the more robust studies we have. And so I think, I can't tell you the exact number of the exact risk to patients, but it's somewhere between 11% and 39% based on the studies we have. And this is the part of the study that I think first caught our attention, was the rate of human error in these patients who were being resuscitated in an ED and got push dose pressors was 19%, so almost 1 in 5 patients. And the authors do a really cool thing where they actually say, here are the errors that happened. 7 patients, which is 3% of the total cohort, had dosing errors. And the dosing errors should make us stop and think. So 4 patients got a 10-fold overdose of epinephrine. 2 got a 10-fold overdose of phenylephrine. And then 1 patient got a 100-fold overdose of phenylephrine. So very clearly, if you're doing this during resuscitation, there's a risk to the patient in terms of this can alter their hemodynamics in an unfavorable way. But then Cole et al. Really starts to shine the light on, we can also screw this up. And in fact, we do screw this up. In addition to the dosing errors, and I would say I'm worried most about harming a patient with a dosing error, almost 1 in 5 cases had documentation errors. I would say if you're pulling my charts, that rate is going to be higher. So that's not a reason, just because we're not perfect at documenting, that does not necessarily impact the patient, but I think it's worth noting. And this is a props to our pharmacists that I think rings true. Only 1 dosing error happened when a pharmacist was present. They don't tell us which one was when the pharmacist was present, but I think that this paints a picture that reflects what we see clinically a lot, which is when we're doing this in the heat of battle, we are setting ourselves up to make mistakes. Having other members of the team with expertise with this technique, I think, is really valuable and can reduce the incidence that we're going to make an error. And so that's it. That is the evidence as far as we could tell as of last week when we last looked. And so on the advanced practice clinician side of things, I don't know where I stand on this. I think if I'm favorable and say, yes, we should use microdose pressors or push dose pressors or bolus dose pressors, I think the physiologic argument makes sense. That's what we hear from anesthesia, that certainly being hypotensive before a procedure like a rapid sequence intubation is bad. And so should we fix bad physiology if we can? And I would say yes, because I think that makes intuitive sense. the evidence-based side of my mind really wants to say no, because again, the body of evidence we have, the quality of evidence we have is bad, trending towards abysmal. We just have small numbers, it's all retrospective. And so I can't put on my scientific hat and really say that this is the way to go. And so I'm probably, you guys will weigh into, I'm probably at a maybe. I certainly have had patients where I've done this, where I think that it was effective and I think it prevented a bad outcome. Again, that's just me retrospectively looking at one case. And so I think the evidence-based answer is that we don't need to throw this away, because I think there's enough on the yes side physiologically. We can't look past the low quality of evidence, but I do think that this is a technique that it has potential. And so that's where I think we can kind of shift to talk about the experience for you guys at the bedside, and also thoughts on how do we make this a better approach for our patients.
All right, so Trent, we want to hear from you about a few things. So what has your experience been with this practice?
So I've had a couple of experiences being in a large teaching hospital, and then some at another job that's in a smaller community hospital. Typically, these patients are given this as a bridge, like we talked about, and it tends to go pretty well. We always have a pharmacist with us that helps that process, and physicians who are competent in giving it. So for the most part, I've seen good patient outcomes. You kind of buy yourself that time to get the drip started and get the patient out of that hypotensive state, whether they need the drip or not. It kind of calms the water and gives us the time to slow down and think and do things right. So personally, for me, it's like a maybe, like Dr. Delaney said, but most of what I see, it tends to work well.
So have you seen adverse events with this practice, or have you not had that experience?
So I have noted some adverse events. Most of it is probably just a lack of education, and that it's newer and we're rolling it out well. You say push dose, grab me, push dose epi, and here at our institution we have the commercially made phenylephrine, or the Neo stick. So that one is, people are a little bit better versed in that, and grabbing it from the Omnicell or the med dispenser, whatever you have. But so I've seen it, the doctor says, give me a push dose epi, and you have a nurse who is in a panic state, and they were running through lots of things, and a physician who's maybe not paying that much attention to what they are grabbing. We got an incomplete order, and they grab this syringe of epi out of the box, and they have that, and they're confused, not sure how to mix it. So I haven't seen any true bad patient outcomes related to this. But as far as muddying the waters and adding stress to the already high stress situation, yes, I have seen that.
How practical is it to quickly get like an epinephrine or norepinephrine infusion at the bedside and started on a patient?
So here, like a large hospital, we have all of the vasopressors readily available and pre-mixed, and I can go and grab one. And you can safely say probably within, we talked yesterday, maybe 2 minutes, if we're prepared and we know that this kind of patient is coming. So you can probably get a drip started at about that time. But there's all these nuances to, do we have the pumps? I know all the hospitals I worked at, that's a struggle, as to where someone, please go grab a pump. We weren't prepared on that end. Or do we have tubing, or whatever supply shortage is facing us this day, or is the Omnicell out of this? So then you've got your programming pump, so you could face some delays there. Also, mixing drips, if you work in a hospital, a smaller one, that takes time and pulls you away from, and you're not just programming the infusion and priming the tubing, getting it connected to the patient. You're also having to do med dosage calc and reconstitute this medicine. You're doing this probably at a smaller hospital where you don't have a clinical pharmacist there, and you're probably working with limited staff. So you've got all these things going, a lot of stress. So probably, I guess if I had to say, well, we can get them done somewhere probably between maybe 2 and 6 minutes. I don't know, depending on where you're at, you could probably get a drip started, which some patients don't have that kind of time. Some do. So.
Yeah, I would agree. I think there are times we have like multiple critically ill patients in the department, and we cannot find like an open channel or pump, and that itself creates delays, even when we have the pre-made bags of norepinephrine.
Right.
Epinephrine. Any other barriers from your perspective with this? process?
It'll all come down the line with proper education, but getting everyone on board with how do we mix it? What's your standard concentration going to be at your facility? Does it work the same in the unit as it does in the ER if you've got flow pool nurses, or having your pharmacist being well versed, and then your docs being well versed in if their bedside staff isn't sure how to do it, being able to give the clear direction on this is how I need you to mix this for me, or grab this specific medicine, this concentration of epi out of the Omnicell. So, and then always having enough pumps, I guess, and right amount of supplies, but that'll hopefully ease over if we get out of this peri-COVID supply chain shortage.
Anything else you'd like to add right now?
No, I think that's about it. It kind of summarizes my experience with push-dose pressors. I have a pretty decent experience with them, and we see good patient outcomes here with them. So for the most part, I think it'd be beneficial.
Mm-hmm. All right, thank you. All right, so I thought we could maybe use a quick puppy break. Okay, so I'm going to talk a little about the pharmacist perspective on this. So I think we can all appreciate the sort of adrenaline-filled, fun cowboy side of emergency medicine. And this, along with the never-ending challenges and variety, are probably big factors in what draw a lot of people to emergency medicine and like the medical ICU environment. So I think, I'm a huge proponent of doing anything needed to help a patient, but also processes that help us maintain a safe environment and set everyone up for success. So with the evidence for benefit seeming weak, but maybe overall supportive, we have to keep in mind these safety implications, particularly when we're analyzing the literature, our experiences, including those at other institutions and various care environments. Several of these studies noted pretty marked dose increases, or like overdoses essentially. Like there was a 1 milligram and I think 10 milligram error cited in some of the studies of like phenylephrine being given. And those really struck me because we would never intentionally give that much to a patient. And so they didn't necessarily remark on the outcomes of those patients, but I thought they were very frightening errors. So what all do we need to consider? So we'll ask you to close your eyes if possible and place yourself in this scenario. So we talked a little about this case earlier, but you're going to be the ED pharmacist. You're called to the bedside to assist in the intubation of this unstable patient. You look at the monitor, the heart rate is 60, their blood pressure is 70/40, and you already have your induction agent and paralytic drawn up in syringes. And when you see that blood pressure, you run to your automated dispensing cabinet to obtain a norepinephrine bag. The rest of the care team is rapidly gathering supplies and preparing for the potential crash airway. And then the attending asks for push dose epi, and this happened when you stepped away. A nurse goes to another ADC. They remove 3 epinephrine 1 milligram per 10 ml syringes, and they hand them to you when you return, saying, "Here, I got you the epi pushes that the physician asked for." And so you respond with, "Oh, she meant, small doses of epinephrine, not code doses." And the nurse says, "Oh, really? Well, these are epi syringes and I push these." So she's 100% right. What do we say when we are giving any medication via IV that is not infusing or an infusion? We say we're pushing it. So I thought a little more about this, and I realized that we should be using language that specifically refers to what is different about what we're doing when we say we are giving push dose pressors. We're actually microdosing them. So one safety measure we could give consideration to adopting is using this phraseology of microdose in place of push dose. So you may have already identified additionally that a complete order may have improved understanding in the aforementioned case. So let's revisit some basics by looking at the elements of this image. This is an illustration of closed loop communication. So S and R depict sender and receiver, and this shows a sender calling out a message. The recipient acknowledges the message by check back, and the sender confirms the message is interpreted correctly. So when these elements are satisfied, closed loop communication is achieved. Now, you may be thinking that a lot of these errors and most errors in medical environments could be avoided simply by improving communication. And you're correct. Ineffective communication among medical professionals is one of the leading causes of medical errors. However, even in situations where closed loop communication is used and includes complete orders such as, I need a syringe containing 10 mLs of epinephrine, 10 mics per ml, the recipient of the message may not know how to prepare this or how to do so correctly and quickly. So I thought about simulation for this. So you may know simulation is used for practice, education, training, and in some cases for maintenance of certification for healthcare professionals and healthcare professionals in training. This is a modality growing in popularity to get our healthcare team trained to function effectively, safely, and at a high level in high stress, high stakes, or esoteric patient care scenarios. So I especially love that we can make mistakes and learn in simulation and eventually achieve mastery without ever harming a patient. So I have a theory that periodic interleaved practice of simulation scenarios involving microdose vasopressors for our healthcare team members would improve familiarity, comfort, and most importantly, the safety of this practice. So how often one uses microdose pressors in their practice could help guide the needed frequency of this of simulated practice. And pre-learning could serve to familiarize all the healthcare team members with the practice and appropriate uses of microdose pressors. So what I did was I designed just a short tabletop simulation for learners to apply their knowledge in a case and learn the proper way to prepare microdose epinephrine for those who practice in care environments where the epinephrine 10 mics per ml prefilled syringe is not readily available. So we'd really like to hear from you guys. So what are your thoughts? What have your experiences been, and what questions do you have for us?
Thank you guys so much for sharing your experience on this. I think we all, this was extremely beneficial in giving us an idea how you do it. And I think there are a lot of thoughts that are going now through the audience. I don't see any questions in the chat, but please feel free to leave a question there, or if you'd like to raise your hand, we can also unmute you so that you can share your thoughts. But to get us started, I had a question. I think you guys referred to this a little bit. You mentioned that you use both phenylephrine and epinephrine, and you mentioned pre-mixed neosticks. What are you doing about the epinephrine? You talked about education, but are you actually physically, are you labeling something, or is pharmacy pre-mixing stuff for y'all? Do you have dosing cards or dilution cards somewhere in the ED to help with that? How do you navigate that?
Yeah, we don't really have like a standardized process for this at this point. And that was part of the reason I wanted to design the simulation I did, because my thinking was just in our ED, we should standardize this, but also we have these emergency medicine residents that are being trained to go to other facilities, and they may or may not have a pharmacist. And additionally, crash cart contents are not, the drug tray, so to speak, is not standardized thing, right? So it might be standardized within a facility. So UAB, you're gonna find the same drawer in any crash cart, but then if you go to like another hospital, you could have very different options. So I usually teach people to use the 1 milligram per ml or epinephrine for kind of anaphylaxis vial, to put it in 100 mLs of normal saline, withdraw 10 mLs, and as part of the simulation, labeling it with a 1 hour expiration, and the concentration very clearly is also taught, because that's another thing I've noticed is sometimes people forget to label it, and then there's just a syringe containing a mystery fluid, and how long has it been there? Nobody knows. So so those are some of the things that I think we could work on from a safety standpoint, optimizing.
We've had multiple events where I would say that our physicians are largely comfortable with the idea that we as the docs can mix it. or we will tell people we're comfortable doing it. And then when we've observed it, it's the Wild West. It'll be a new nurse, hey, grab the crash cart epi. It's easy. Just put it in a 10cc syringe and squirt the rest out, put the flush in. And despite the fact that it's not a complicated process, the number of times it's gotten off track is innumerable. And we've actually tried to kind of ban years ago. We were like, we have to quit doing this because specifically the epi, everybody's got a slightly different way to do it. And everybody's convinced that their way makes sense and is easy. And the bottom line is that it doesn't seem to be consistently easy for us.
Yeah, another, what I think you see most frequently in the literature, and Paul remarked on this in their paper, but if you try to measure like 1 ml or 0.5 mLs out of the 1 milligram per 10 ml or cardiac, as people call it, I just call it a code epi syringe, the measured amount is usually very different from your intent. And so I think their study was, or the study he cited was 0.5 mLs was the attempt to measure, and it was usually 0.9 mLs that they actually got out. So people were getting more epinephrine than intended. But what we have to keep in mind is like what is readily available. And I can't say it's universal, but I would assume that in most crash carts, you're going to have the 1 milligram per 10 ml epinephrine. And so an option there, aside from using like squirting 1 ml into like a syringe containing only 9 mLs of saline, if you have 100 bag of that, I think you're going to be more accurate. So you could inject the 1 milligram per 10 ml syringe into 100 mLs of normal saline. Now your concentration is going to be just under, it's going to be between 9 and 10 mics per ml, but it's still so close. I think it's probably good enough.
Thank you, Les, for your thoughts on that. We have a few questions coming through the chat. So I'll start off with the first. What are your thoughts on restricting to physician administration only? I know Dr. Delaney just highlighted a little bit of that. Allowing for a double check of the dose preparation before administration. After a med error occurred at our hospital, a nurse pushed back on administering microdose pressors.
I hate physician only doses of anything because we are not the most experienced at measuring or giving drugs. If you just think about the average encounter in the emergency department, I give no medications. I put in orders. I can do verbal orders for some medications with closed loop communication. So it's always a little strange when we say when the stakes are highest, that's when the physician alone should do it. And usually the first thing I hear out of their mouth is, what is this and how much should I give? And they're asking the nurse, the pharmacist. And so I think from the physician side, I am not safer than them. I'm probably more dangerous than you guys. I do this task less often. And so I would be a fan of a system where there's a, have a hard stop. Everybody knows what we're doing. And at that point, I don't think it matters who's physically giving it. Because I think I bring some skills to the table that these guys don't have. This is not an area where that's the case. This is there in y'all's wheelhouse. And so it's a little strange that I am the last kind of line of safety. So I'd be fine. Anybody knows what they're doing. Let's build a system where it can be safely given by anybody.
I kind of think of this, I guess, as a little bit like I do ACLS because one of these papers they looked at, I think it was Gottlieb, it was like mostly post patients. And so when we do ACLS training, we don't single out tasks by discipline, right? Like you have to be able to do everything to pass ACLS or BLS even. Like I don't do compressions typically or ventilate patients in the ER, but guess what? I have to do it in those simulations to get certified. So I would argue that we all need to be comfortable with this practice and understand it, understand the math behind it, be able, and when you can do it comfortably, frequently under environments where you don't have that pressure, then you can maybe translate it more to the time when there is pressure involved, when the patient is crashing.
And Trent, you guys saw this during COVID because prior to COVID, only physicians in our system could push paralytics or intubation meds. And as soon as we decided that that was a task that we needed to offload it from the physicians, we did brief interventions with the nurses, and you guys are totally able to do it. There hasn't been a drop off in safety. Patients aren't dying because we let someone else push the syringe. So I think, yeah, Emily, I think it's less about who's doing it, about does the person doing it know what they're doing?
Right, I agree with what you both have said, and I think getting everyone on board with how to mix it is a big part. I personally, when I mix it, if I've mixed it, if my pharmacist is doing something else, I double check it with them. If I am in a setting where I don't have a pharmacist, we label the bag and double check that this makes sense to you. I pulled 1 ml out of this maybe 30 milligram vial of epi and I put it in a 100 bag. Does that make sense? Now that I have 100 micrograms of the syringe, you label your syringe and hand it to your physician. I guess like all drugs, you need this double check and being comfortable as a nurse giving it. I guess it's going to vary on just the environment that you're in. So I definitely understand this other perspective of an RN being, giving pushback after an error happened with it, just because it is a high risk drug. But the reality is, with all ACLS meds or any med we're giving, they're all high risk, right? So it's more about, in my mind, what can we do to educate to put, stops in place so that errors don't happen with, paralytics and induction meds, same way.
Yeah.
So
I think the only other thing I would add there is, the physician leading the resuscitation effort already has a very high cognitive load, and to add, this potentially like problematic or complex math that may cause errors, I think is not the best person to say, like, you need to make this and then you need to give it. And so ideally, you have a pharmacist involved, but I know in a lot of smaller emergency departments, that's not always, you don't always have a pharmacist present. So
yeah, we didn't say this earlier. I would rather never do this. If I could get an infusion, I'd like to do that, because in resuscitation, like you said, the cognitive load is high. I just want the numbers to be better. I don't care how it happens. And so if it's a couple little pushes, great. But that's a whole nother practice. That's a novel thing we do, because we don't dose other medications. We don't administer other medications that way. So if you gave me an immediate norepi infusion, I think from a safety standpoint, I would prefer that. And again, we have such a low quality of evidence to support this. I think it's fine to do, but we find ourselves building systems to make something safe, where if it's just as easy to get an infusion, I think most of us would say, let's just do that and titrate that up.
Mm-hmm. Yeah, and I think Cole alluded to that, like they actually looked in those video reviews from the time the physician said, I need a norepi infusion or whatever the vasopressor that was called for, and then at the time it was infusing to the patient, it was usually about 8 minutes. And I think that's pretty realistic. I mean, particularly if there's trouble finding like a pump channel or an operational one, because that can be a challenge sometimes.
Thank you guys for that. Our next question is asking, are you aware of any restrictions on nurse administration of IV push vasopressors outside of cardiac arrest?
We kind of discussed this a little bit, and I couldn't really find any. Our hospital doesn't, that I'm aware of. The ED certainly doesn't, and the medical ICUs, a couple of them, they don't have protocols on this. So I'm not sure, what a board of nursing standpoint would be on this. I'm sure that it would very much so be hard to push through. I'm not aware of. There's a couple hospitals that have a policy that I was able to find online. And it seems like they do have something in place where RNs administer this, maybe in a setting where they don't have a physician. They're maybe taking a phone order or something like that, that they can administer this, but I'm not fully aware of if there are restrictions per se. But it also, with this being such a new practice, is this, maybe that's why there are no restrictions in place. We're not very well versed in it, so it maybe hasn't made its way to needing to implement a restriction. I don't think anything different on that.
I mean, it's really just a dose of a medication. So I would hope we don't restrict it more, and we focus on right dose, right patient, right route of administration, rather than putting up barriers about who does it.
Thank you for that. I had a few questions regarding like how to do this safely, and please, as the audience has more questions, please feel free to type into the chat box and we'll be happy to share those questions as well. But I wanted to ask y'all, A, do you have that on override in Pyxis? I'm assuming epinephrine, yes, would be overrideable, but how about the neosticks? And B, have y'all, in your practice, have you guys as a group decided to use like specific doses? We're going to do 50 mics of phenylephrine and you repeat that, or however the neostick comes. or like what's your practice in terms of dosing as well?
So we have currently non-profiled automated dispensing cabinets in our emergency department. So, and we have multiple dosage forms of epinephrine, available. So we've got the anaphylaxis, the vials normally used for anaphylaxis, which is 1 milligram per 1 ml. We have the code syringes of 1 milligrams per 10 mLs. We have the phenylephrine. Ours is 40 mics per ml with a total of 10 mLs in the syringe, or 400 mics. And we had the phenylephrine pre-filled syringes added right as quarantine started, I believe, because we were having, these COVID patients come in that were crash airways, and we had sort of advocated like, hey, we need to be able to intubate these patients as safely as we can. And so currently what we have in place is a statement or like an acknowledgement on the automated dispensing cabinet when a nurse or pharmacist is removing the phenylephrine syringe, that it can be administered by an ED attending only. And I think I forgot the other part of the question.
How do we standardize how much we give?
Oh,
right.
yeah.
So I mean, typically we give, you guys probably are better.
40 mics.
40 mics, 2 mLs. Everyone kind of knows. We give the phenylephrine stick, the neo stick. You get 2 mLs or 1 ml maybe. You see someone give more than that, it's like, oh, that was maybe a lot, but I don't know if we have a standard.
When we added the phenylephrine syringes, we did some education, and we advised on dosing of 40 mics to 200 mics at a time, and no more than that. And I think every like 2 minutes or so is what we said. I think that,
I was actually going to ask about the frequency too, and like at what point do you start hanging the drip, or are you always using it as a transition to hang the drip? And how are you handling the transition? So like as a nurse, Trent, when you're getting ready to, like there's another nurse that's going to take over care, how are you handling that handoff regarding, hey, pressures look okay because I just pushed phenylephrine, but really this patient may, drop in 10 minutes or so?
That's a great question. I personally haven't been in a situation where I needed to give handoff in a way that they were still stabilized by this microdosed version of the vasopressor. So I'm not experienced in that, but that is an interesting point. If it works in the way of just providing a bridge for some peri-intubation hypotension, I guess I would, I probably, usually we already have the strip pulled, it's hanging at the bedside, the pump is programmed and delayed, right? So you've got this, we already take some of that delay out. Hey, the order is already in, the doc's already said, this is what we're gonna go to. We've been adequately fluid resuscitated, we've had trouble with their blood pressure. So if it continues to fall, just start the infusion. So that's probably where it takes out some of your need for continuing to give microdoses of any vasopressor. You had time to now prepare for the infusion.
I would say the majority of the time, if microdose vasopressors are being requested, also the continuous infusion is being requested, and it's all being mobilized simultaneously. And it's just that we see that delay potentially in getting the infusion actually infusing into the patient, and that's typically that bridge that's alluded to in several of these studies, and I would say that's frequently encountered for us in practice.
Yeah, that's again what makes it so wacky. This came from healthy people getting elective surgeries and getting anesthetics. So those patients arguably need a bridge less because that would be a transient thing, yet they end up getting infusions when it's been looked at. So I would say just the what evidence we have would say almost certainly our patients are going to end up on an infusion, unless it's like a peri-procedural, like, oh, they got a little soft pressure on propofol, which would be a great use for this actually, but no, it's typically it's just doing something till the infusion shows up.
That's very, very helpful. And just like to, I guess, make sure like all our audience knows, is that typically a peripheral administration, or do you have a central line by then? And do you guys, especially typically when we're hanging a drip, we're expecting that we're establishing central access, but do you have any practices around that in terms of which agent, where peripherally, how many doses, what kind of dose?
Of course, we know it's, like you said, central line preferred, but I don't think no one wants to, we're not going to delay care for the patient while we wait on a central access. We typically go for, you want AC or higher, 18 or bigger, right? And typically we were able to get those things with, whether it's ultrasound guided or there's EJ, we have some sort of emergent access. So peripherally, if the concentration is so low, if I understand it right, it's almost like giving lidocaine with epi. So maybe it's not is it a huge deal really? Emily's probably our expert on that. If it, give it peripherally.
Well, I mean, I would hold that same viewpoint that we would never delay, therapy due to the line. And, there's been literature emerging on that in general, like 3% should not be delayed by getting a 3% sodium chloride, should not be delayed to get a central line when it might make a very timely difference for the patient. And I would say a similar philosophy maybe here holds, is that this is not like an incredibly concentrated form of these medications. And if you were to calculate kind of the rate the patient is getting when they do get an infusion, this is very similar amount of drug that they're getting just in this microdose bolus or push. So I think when the patient does warrant a central venous line, we certainly pursue that, but there are also risks, inherent in placing central venous access. And so I think that's kind of a risk-benefit discussion that comes up.
Yeah, it's interesting. I've never thought about it. We've moved pretty strongly in our shop towards infusions of vasopressors through peripheral lines that are good peripheral lines where we can monitor them. Because when you look at like how do we mess patients up with extravasation, it's typically the infusion that extravasates, we don't see it. So you're pumping a lot of volume, a lot of concentration in there. I couldn't care less. I'd let you give me epi and sub-Q right now on me, and it wouldn't bother me. And so I think not that it couldn't potentially cause trouble, but I think to your point, the concentrations are low, and specifically we're giving this microdose as a push. I'm right there with the syringe watching it go into the vessel. So I think I worry almost none about the microdose needing a central line. Yeah, down the road we may need access, but in our shop, I've never heard somebody say, can we give this through a peripheral? It's just kind of, it seems to be a safe enough practice.
So much for that. Emily, I know you spoke a little bit about simulation. So do you guys couple that with your like ACLS training, and is that part of your like onboarding of new people, or is that part of yearly skill management for the ED team?
It's not currently, but my goal, unfortunately, I was doing, so I created this during my master's program when I was getting a master's in healthcare simulation as my capstone project, because I thought like, hey, this is something we actually need, and I can get a double benefit by using it, in my master's program. So unfortunately, I was doing a lot of that during some of the peaks of surges with COVID, and we've not widely deployed it yet. But my hope is that we can essentially, I basically going to do a version for physicians, nurses, pharmacists, and pre-hospital providers. Our EMS do have the ability to make microdose epinephrine as part of their state protocol, and I believe that's the case in some other states too. And of course, the same safety implications that there are in the hospital are present in the pre-hospital environment, maybe even more. So my hope is to kind of adapt this for each of those populations and maybe include it in some skills, or I've piloted it with a few residents, and I hope to kind of do that with a few more to get everybody comfortable.
Sounds like a great project. I hope you guys get to collect data and publish on that, because I think it would be really, really helpful for different teams across the country, really. All right, I don't see any other questions in our chat. Oh, I see a hand risen by Kathleen Jurgensen. I'm sorry, I'm not sure when you raised your hand.
Kathleen, if your hand's up, we're here for you.
Let's hear it.
Kathleen now puts her hand down.
Okay. I can't unmute you, but I don't know if I should, because I don't know if you're still have a question or a comment. Oh, said I'm good, thanks. All right, wonderful. Okay, well, I'd like to thank all of you again for joining us today. Dr. Delaney, Dr. Green, and Trent, you guys have been wonderful. We thank you for taking the time to look at the literature and really walk us through your practical practice. It's very helpful for us to have an idea of people who are doing it and how they've been able to adjust for it. So I would like to thank you again. If anyone on the call has ideas for bite-sized lectures, this was a great way of delivering it, truly bringing us information from the bedside. So if y'all have ideas, or if you have groups that are interested in holding this, please let us know, and we'll be happy to host the next one with your group. We thank you again for taking the time, and we hope you benefited from this. We're planning on posting this on our YouTube channel once it's uploaded, and hopefully we'll be able to include a blurb on this as well in our newsletter. Thank you guys again, and we hope you have a wonderful rest of the week.
Thanks, guys.
Thank you.
I forgot to tell them that I did not find a pharmacy resident interested in writing it up.